That's so exciting.
Well, so thank you for putting all those great resources together.
Thank you for watching.
I went through a lot of it. I feel like Kahoot would probably be the most fun way to do this. So, so can you guys all hear that fantastic background music? Now, does everybody know how to do Kahoot?
Yes.
Okay. And can you see the game pin number?
Yes.
Okay. And do I need to close down my window so that you can see better? Does that make a difference?
No,
I don't
think
think so. Yeah.
You can see that. So as everybody's getting signed on, I see THO so far. I think we wait until everybody's names appear here, correct? Strab, what a great nickname. Tropical Llama 75, these are great names. THO, toe.
THO
Right.
is mine, and I'm embarrassed about it. But the thing is, I meant to hit the back space, and it submitted it.
Sean,
So what are you gonna do?
I've never known you to be embarrassed about anything. So
Where did it go?
apparently, when you said you were embarrassed about it, Kahoot was like, "Well, then maybe we don't want you."
What is this? Connection lost.
Get back on there and get a new game. Oh, are you back?
It won't let me. I'm THO.
No, you're the O minus an E.
The O.
And then there's an E
The
here
big
next
O.
to it.
Oh my gosh, wait, the E is me. I was coming up with a funny like ET phone home, kind of like ETXO, and then it just submitted me. It didn't even wait.
It's so frustrating. I'm so sorry.
Okay, well, I'm E.
This is
Huge deviation. I like
So
that.
sad.
so good.
Wait, I wanted to be ET phone home.
Strap Queen, I love these. So do I not get to know who's who except for Sean and E?
I think we find out at the end when we usually like to reveal at the end when there's winners for losers.
Okay. Sean, are you really gonna go? Are you gonna redo this? And Catherine, looks like you're trying to do it again.
Oh, let me see.
No, back on. Sean's just off and on.
I don't think it's gonna let me, so it's okay.
Okay. How many do we have? Is that everybody? 1, 2, 3, 4, 5.
One more very important player.
I am not going to join if that's okay. I'm post call and I'll just join a little bit and listen in.
It's fine, Lydia. We know you'd win anyway, so we don't want you in the game.
Wait,
Of course I would.
Sorry, I didn't realize the link just went live. Let me join the game.
Mine keeps ignoring.
I'm about to be a patient, so I don't want to have you duck out halfway through the game, so I won't try.
So I had a really clever name, but it just gave me Joyful Dolphin.
Oh, it's great.
Which is better than Tropical, whatever.
Okay. It's probably good. So I did do I selected a minute for each question, which may be a little bit longer time, but it ends as soon as everybody guesses. So I think we'll be fine. I'm trying to think if am I good to go? I feel bad that it seems like Sean and Catherine, yours keeps coming and going.
We'll just have to move on without.
On my screen, it looks like I'm in.
Oh, okay. For some reason, mine is down to 9. If I hit start, is it going to keep people out?
Wait, now I'm out. Now I'm out. Now I'm out.
Okay, now I'm in.
They
Yeah,
can
if you
also
use phone
rejoin once
timeout,
you
it-
start.
Yeah.
People can continue to join.
Oh,
They
boy.
can. Okay, so I'm going to start then. Okay.
4942377. Okay.
Why don't we just put it in the chat real quick? We'll start here. I'll just throw it over the chat.
I think it actually stays at the top.
It does.
I think so.
God, you guys are amazing. This is my first time with Kahoot, making my own Kahoot. It was very exciting. So I'm going to just start.
Oh, it doesn't. Oh, wait. I think it's on the left. Okay, anyway. Get ready to lose, everyone.
This is good music. Whoa, really good music.
Mine is pretty wonky. All I saw was 4 colors. I didn't see a question or anything, so I just picked one. We'll see how I did.
Like that attitude. The kind of a no quitting attitude. So
Does this person also have heterochromia? What's going on with those eyes?
totally does, just to throw you off. So let's talk about this real quick. The answer is bilateral lateral rectus recessions with tendon upshift. If it's okay with all of you, I would love to make this more interactive. Somebody who got it right and who understands the question, or somebody who got it wrong but now understands it, I want you to just explain it to the group.
I always think about when you're fixing A or V pattern, the male mnemonic. So medial rectus to the apex, lateral rectus to the empty space.
So you got a V, so V is like this, so the empty space is up, right?
Yep.
Now the other options include possibly doing inferior oblique surgery. Why would you not do inferior oblique surgery to correct this?
There's no inferior oblique overaction.
Fantastic. Is there any questions about this scenario? Anybody want another wrong answer explained? I'll give you. So those who picked green, for boards that would be wrong. In real life, there's some controversy on really whether or not shifting makes a big difference. Sometimes just doing a bilateral lateral rectus recession alone does actually collapse the pattern a little bit, and sometimes tendon shifting, especially when done poorly, causes more problems than fixes. But for boards, this is exactly, and this is actually, I wanted this to also be OCAPS prep, just given the season. So I'm going to give you the correct answer as to what would be on boards and OCAPS. But I'll try to give you a caveat if there's something more to it. Does that sound okay? So so I go next, okay. Ooh, okay. If I hit skip, does it skip the question or just skip to the answer?
I don't know actually. Did everybody answer?
They're all correct.
Oh. What?
God, what? Blow your mind. Okay. That was almost kind of too tricksy. The what's the finding?
Cherry red spot.
Yeah. There is a pretty significant differential. There's like 3 or 4 other diseases not on here, all of which can cause a congenital cherry red spot. Isn't that wild? I did not realize so many things could cause it. What's not on here that you are all looking for?
Tay-Sachs.
Tay-Sachs disease. I'm including this now. This is not necessarily the strabismus, but I'm including this partially because I saw this for the first time a month ago, and it's an interesting and sad story. But the 5-month-old baby came into clinic, wasn't tracking really well. Mom already kind of had a full-blown anxiety panic attack in her pediatrician's office, and the pediatrician's a friend of mine, and said, can you get him in ASAP? And they came in, and I saw what I thought was cherry red spots, and did an EUA with Eileen Wong and confirmed it, and then got genetic testing, and they turned out to have Tay-Sachs disease, which apparently isn't on the newborn genetic screen in Utah. What's the prognosis of Tay-Sachs disease? Anyone know?
People die in a couple of years. Oh,
Yeah. It's one of these neurodegenerative or lipodystrophy disorders where your kid is normal for several months, maybe a year, and then eventually they have this horrible decline of losing motor control, neurological regression, seizures, total loss of kind of function, and death within under 5 years. And I had to break that news to those parents, and it potentially was about one of the hardest things I've ever done professionally, as mom and dad just sobbed uncontrollably for about an hour. I just can't even believe how terrible of a disease that is and how sad that is. So I hope none of you ever have to do that. But I do think in medicine, we really had anyway, it was so powerful to just be with this family and to just sob with them for almost an hour. I mean, it was awful. But these parents were really remarkable in the end, and talked about how they're just going to savor every day they get with this child. And we got them into counseling, as well as got them into genetic testing and all these other things. It was a really harrowing experience, but I can't stop thinking about it because it was so recent. So,
Dr. Jardine.
Yes.
True story. As a PGY2, I was called for a cherry red spot evaluation on a consult, and it was Tay-Sachs as well. So I feel like it's rare, but you can see it here.
Yeah, and I think it's really unfortunate that it's not on the newborn screen. That's one that parents really should know about at birth. But it's going to be heartbreaking whenever they hear. So maybe giving them some months of normalcy isn't the worst thing. I don't know what the answer is there. It's pretty sad. But yeah.
There are a few benign cherry red spots like sialidosis, which has normal life expectancy, and it's just a finding that can, in very rare cases, but we saw a patient and their siblings have the same finding, and that's a benign cherry red spot that can also be possible. So I think that should always be on the differential as well.
Lydia, fantastic point. And I think that's why you wait till the genetic testing comes back before you lay the hammer of the kind of horrible prognosis, because you do need to confirm what is the cause. And I guess that's the point of that question, is that it's not always Tay-Sachs disease. So Lydia, fantastic point. I almost forgot to make that. Thank you so much. You sure you want to play, Lydia? Because that's pretty impressive stuff. Okay, we'll keep going.
Next year.
Yeah. Once we get 8 answers or 9 answers, I think it's where we're hitting is the max. Is that right?
Yes.
Am I expecting one more, or is 9 the total?
I think it should actually time out after 9.
I think there's one other person though that it thinks is playing.
Oh.
I'm gonna try to skip and see if it hopefully doesn't ruin the question. Oh, it doesn't. Okay, so skip, just go to the end.
Yes.
What is hot water?
Oh, dang it.
That's actually me. I think that Tyler and I just look the exact same. We're perpetually confused.
Oh no, did I screw it up? I'm so sorry. Jordan, it's Jordan who did this. Is
Yeah.
that Jordan? Jordan, I was going quickly last night through the emails and I did. So if we can't throw it out, but it's Jordan who almost exclusively drinks hot water year round. Okay.
Are you
Jordan,
laughing, Catherine? Because you do too.
Well, no, it's not me.
Okay, we'll keep going here.
Dang it.
Sorry for all the typos. Whoops, there's a lot of typos in there. Whoa, so sorry about the I actually think, oh, I should have made this one a right one too. Oh, I screwed this one up. So let me go through this real quick. I think clinically the red one's the right answer. That's just not that much of an improvement. And accommodative esotropia has such a range of responses to the glasses. For boards, the green answer is the right one, and OCAP. So you all got this right. 5 of you got this right, and I didn't give you credit for it. I meant to make this a multiple correct option one, and somehow I forgot to. Please don't be angry with me. But bilateral medial rectus recessions, if our clinic were so often behind, they typically get a really great cycloplegic dilation. And if I'm not seeing a big improvement in the glasses, and there's a young kiddo, I tend to not want to just keep fussing with this and redilating and retrying it and pushing glasses. We'll talk about other scenarios where you may have some of these other things be right. So forgive me that those who picked 5 probably also could have got that right. I think that doesn't alter too much. Okay, we'll keep going. Primary gaze, this is what is the main gaze abnormality, not as in like looking straight ahead primary gaze. So are there 10? It looked like it closed out last time. Okay, if somebody's still waiting to answer, I'm going to skip it in 3, 2, 1. Bam. Okay. Whoa. Great job, you guys. Anybody want to explain this real quick? What this looks like clinically? In fact, could somebody turn their camera on and show me what this person does when they look side to side with their head? I need an impersonation. Who can do it?
I don't actually know accurately, so I would, but I don't know if I could demonstrate it correctly. Anyone
Okay.
on neuro more recently, or?
I'll give you a demo real quick if people don't mind. So if I want to look to the left and I can't initiate, so I can't jump my eyes to the left, what am I going to do? I'm going to turn my head to the left. I'll look at the camera. So I'm going to turn my head to the left, but because of the doll's head maneuver, my eyes are actually not going to go with me until I get past kind of a certain point of threshold where they can't look anymore that way. And then I'm going to go over to the left. And if I look to the right now, I turn my head and then my eyes kind of catch up and I overshoot until they're fixating on the target and come back. So it's like this. So I go, Did you guys get to see it? Oh, my lights are off in here. Okay, we'll go back to the game. Any questions about that? Can you all see the game?
Yes.
Great.
Oh my God. These are all so good.
Excellent choices.
And the good thing is, the fun thing is that I wouldn't put any of these past Sean. Oh, you guys got to, oh man, I thought my distractors were so good. Okay, Sean, do we need an explanation for this?
I think it's pretty straightforward. I was pretty tired, and she had this funny accent, so I thought I'd do a funny accent too. And then the other nurses' jaws just dropped, and they were like, anyway.
Okay, so
something
good.
out of Dumb and Dumber in real life.
Just when I thought you couldn't get any dumber, you went and did this, and totally redeemed yourself. Okay, here we go. Moving on. Great job, everybody. This is another kind of non-strap question, but I saw it recently. I don't know how many of you look carefully at the image that is created on biometry, but okay, maybe one more. 3, 2, 1. Here we go. Isn't that picture impressive? What did you notice about that scan? I'm sorry that the picture goes away. Somebody describe to me just kind of what is abnormal about that picture.
Yeah, the contour of the lens just doesn't look like, the lenticular contour is usually a little bit more spherical on one end and then a little bit more flat. And that one just looked like a big round sphere.
What was the anterior chamber depth, Catherine?
Oh, it looked I didn't look at it, but it looked really shallow.
Yeah, I mean, I don't know if I can go back, but it essentially, the curve of the lens and the curve of the cornea were like right next to each other like this. It was like less than a millimeter. I had never seen this until the last 3 months, and then I've had 2 new patients come in. And what's so interesting is that they're -20, and so I'm looking in their eyes. And what do you expect when you look at the retina of a -20 patient? Even in a child.
Very myopic changes, perifibrillary atrophy, sort of tessellated on the
tilted nerves, thin RPE, prominent choroidal vessels that are visible. The retina was pristine, perfectly normal. And so I'd never seen this, and I thought this is just totally incongruent to be -20 and have a retina that looks like that. And so we got biometry, which made the diagnosis. So I think always pay attention to incongruities in your exam. I just think that's the take home there. Things are looking pretty good here. Okay. Ooh, very nice. Who will explain this for us? Whenever you're ready, just go ahead and explain it.
Atropia is when you're just doing cover uncover, and then aphoria you're doing alternate cover. But I think my rationale is as you're going from as you're also, it kind of depends also, the more that you do the testing, it can bring out the tropia and the phoria, and you can basically measure the maximum measurement of both. That was a terrible explanation, sorry.
No, I'm so grateful for you shooting at it. I think it was great. One of the ways to think about it is, so atropia is what is manifest just walking around without any testing. But once you cover an eye and you totally block any visual input, the eye loses the visual input to guide some degree of motor fusion. And then that eye eventually just relaxes to its full deviation. And that's the phoria. So think about the phoria being when you block an eye and there's no input to guide even modest alignment, because modest alignment then, or modest or motor control, then you're going to get the full deviation. Does anybody have any questions about that? This is not easy for those who have not done the PEDS rotation. But I certainly want to explore these things. I want this, you know, did anybody have any other questions? Or should we just keep going? Okay, I'll keep going. And then I want everybody, I don't want to call people, but I want everybody to at least try to explain one answer, even if you don't know. The process of trying to explain it actually is a great way to learn. So I want everyone, so just know that everyone's, if some people don't have the chance to speak up, I'll start calling on you, just to make sure that we're including, getting everybody involved. The child on the left is representative of Catherine.
Yes, definitely.
But that's strawberry.
Catherine, what's the explanation?
I just really like vanilla. Like when I get cookies and cream, I like to eat all the cookies, but then my favorite part is the vanilla. And then some people are like, when I was little, people would be like, vanilla, that's a boring flavor. And then I would say, well, you're a boring flavor. So I just look at that. So, you know.
Spicy, Catherine. Well done. Way to hold to it. You know, that just because it's simple and just classic does not make it bad. How do you measure, take out this, I'm so sorry. How do you measure only the manifest portion of atropia, or simply how do you measure only the tropia? There could be multiple right answers on this one. I may screw this up. So cover on cover testing also would measure it, but let me clarify. Cover on cover testing is where you look at a patient and you cover one eye and you uncover it. And you just see if there's a refixation movement in the other eye. So if this eye is out, if my left eye is out and you cover my right eye, my left eye will snap in and you'll see that movement and you'll know that there is atropia. This is where it gets confusing. Cover and cover detects the tropia. Simultaneous prism cover testing is where I know my left eye's out. I'm going to cover this one and I'm going to throw the prism on at the same time. And I'm going to see if I can neutralize that refixation movement. So cover and cover testing detects atropia. Simultaneous prism cover testing measures that tropia alone. It's so tricksy. Does anybody have any questions about that?
No, that was a great explanation.
It's a confusing thing. We'll keep going because I want to get through these questions, so and not give you some extra time left over, hopefully. A lot of these are tricksy, but you know, hopefully it's just making it more fun.
Do we have this question already?
Did we just have this?
There's a very critical difference.
The second measurements are different.
The second measurements are actually the exact same. I'll give you the hint. The first question didn't have parentheses on the T.
Oh no.
Parentheses means it's an intermittent deviation. If it's just an ET, it means it's a constant tropic deviation. This is so tricksy. I'm grateful this isn't a real test, because there'd be all sorts of upset people with having all these answers be not so quite so fair. Oh, so mean. Depends is the right answer. The worst. Anybody want to take a guess? Depends on what? Abigail and I, we've been talking about this a bunch. Abigail, I hope I don't mind me picking on you.
Yeah, so we talked about this a little bit. So it depends on
with any intermittent deviation,
like it
the
can
decision,
build, right?
What's that?
The deviation can build. Sorry, I've been having issues with my audio lately.
No, you're fine. I can hear you. So what does it depend on? The decision to do surgery depends on what?
Is it?
I think the amount of deviation, but also the consistency.
Yes, you're very close. Not the amount or the magnitude of it. It depends on the. Go ahead. Ooh, yes, but even there's a question before that would determine whether or not they would be at high risk for amblyopia.
If they have like good, fair, or poor control.
Yes, control. So this is really gets tricky. You could have a patient that has a huge deviation but great control of it. What would you do in that situation?
If they had poor control, I'd be more inclined to do surgery.
Yeah,
if
they had poor control,
then
yeah, exactly. So depends on control. So and you don't add bifocals here, and the green answer also probably would be not incorrect for boards purposes. But in this case, it really just everything you do depends on the control of the deviation. So I'll keep going. Unless any other questions.
Jardine, but don't we? Isn't control more applicable in XT, or is
typically yes, but people sometimes forget that it's still certainly present as a big deciding factor in ET, and accommodative ET in particular can have control becomes a big issue because they because you get so much of accommodative esotropia falls into the category of partial accommodative esotropia, where the glasses make it better, but they don't take their alignment all the way to ortho. They'll get it less, and then they'll be able to control that smaller amount to varying degrees, and that control is what determines whether or not I need to try to push, bifocals or consider surgery or just observe.
Cool.
So it's a major issue in intermittent XT, no question, but it's overlooked as still being a present issue in ET.
Gotcha. Thank you.
Great question. I'm gonna keep going unless people have other questions. Is this pace okay? Do you want me to take more time on the questions or less time, or is this okay?
This is great.
Okay, please, if you feel, I feel like for PGY 1, 2s, and 3s who haven't done the rotation, if you have questions, I think everybody would benefit from you asking them. So please ask questions. The picture has nothing to do with it. I just wanted a picture of eyeballs. Nice. Who could explain this to me?
I can give it a shot. So Sherrington's law is of yoked muscles, I believe, so that when your medial recti, your medial rectus in one eye fires your lateral rectus, relaxes your sort of antagonist and agonist pairings. And then Herring's law is the other one that is applicable to things like DVD, I believe.
Yeah, so you're exactly right, but let me just make one correction, Sean, just to be accurate and precise here. The yoke muscle refers to the muscle that is yoked in the other eye, and that's Herring's
so that's
law.
actually Herring's. Yeah.
Yes. Yeah, but you use the correct phrase, which is the agonist antagonist relationship is Sherrington's law, meaning when one contracts, the antagonist needs to relax. So you use the right, you can use both terms, but yoke, I think, is more exclusively used in the context of, so in Herring's, what's the other one? Not Herring's law. I'm trying to.
Isn't it Herring's law?
Is it?
Herring's law is equal and opposite innervation, right? And then the yoked muscles is
yeah.
I'm pretty sure you.
Hey, is it? I just forgetting to know the name of the other one. Is it Herring?
Herring, yeah.
I'm driving like hey. So, but Sherrington is this idea that, so in a Duane syndrome, you have often an absent abducens nucleus. So the third cranial nerve ends up kind of spreading its innervation to incorporate the lateral rectus. The problem is that the whole relationship of when one muscle pulls, the other one relaxes, gets thrown off. So in Duane syndrome, when the lateral rectus, it depends on which type, but let's keep it simple and just say they have type 1, which is they can't abduct, meaning type 1 and 2 and 3, you add up the number of Ds. Abduct is just 1 D, so that's type 1. So let's say the left eye has a type 1 Duane syndrome. As this eye goes to look to the left, this one doesn't look to the left very well. It does have some contraction of the lateral rectus, but the problem is that it's the third oculomotor nucleus and nerve that's sending that information. It's kind of like almost like aberrant innervation, if you will, but it's from birth. It concomitantly also tells the medial rectus to contract. So instead of the lateral rectus contracting in the eye pulling out in the left eye, both the medial and the lateral rectus contract at the same time, and they pull the eye in. And what happens to their eyelids?
They close.
Yeah, because you're sucking the eyeball into the socket because there's co-contraction, so they get the squint when they look to the left. Any questions about Duane syndrome? Hopefully that gives you a little. That's a very common classic OCAPS boardsy question.
I think we're good. I was just going to say that the video where Dr. Dries explains Duane syndrome is probably the best explanation, where he just says that like there's a lot of rewiring of the brain and the cranial nerves. So that was a good refresher for somebody who hasn't watched that video in a while.
Awesome, thanks, Catherine. Fantastic. Okay, so we'll keep going.
It could literally be all 4 of these, Ariana.
You must have got it. I thought this was a great answer, Ariana. Great submission. Ariana, do you want to offer an explanation for this reaction? Are you there, Ariana? 5, 6, 7, 8, 9. She may be occupied.
Oh, Dr. Jardine, I was jumping and shouting around the room about getting this one right and using it to pass Cole. So I'm sorry I didn't hear what you said.
Okay. I just said, is there any sort of explanation for this reaction that you wanted to offer the team?
Oh, you want me to dig deep into my childhood? Do this after lecture?
Gosh, I've got a lot of typos. I'm sorry. I read this last couple of days, try quickly. No, you know what? We'll save. Now you come to my office. We'll talk about it. Okay.
Thank you.
So it's a great response. It's a great reaction though. And I do love that Catherine thinks that any one of those would be possible. Okay.
I think we're at 9.
Is there one more coming? It's been ending early here a few times, but I'll keep going. Okay, if there's answers. Okay, I'd like a PGY2 to explain this.
I think there's only one. Me.
There's
So
only one.
deprivational amblyopia. Why is it most time sensitive and potent? I don't know.
Yeah.
I guess because you're covering one eye or both eyes.
Yeah,
I
it's.
don't know.
You think about which of these probably has this most significant decrease in sensory input, and it's deprivational, right?
And what if it was deprivational bilateral?
So interestingly, what do you think, Tyler? What would be more time sensitive, a bilateral congenital cataract or a unilateral congenital cataract?
Probably unilateral congenital cataract, but
That's exactly right. Any thought as to why?
The symmetric versus asymmetric input.
Yeah.
I don't know.
So what happens is with unilateral deprivational insults, the brain is still getting sensory input, which is stimulating the vision development of the good eye, and that ends up causing an overtaking of the if you will, the visual cortex real estate of the bad eye. The brain wants to just give, cortex real estate to whichever eye is seeing well. And so if one eye is totally blocked and the other one is seeing great, the brain will just rewire itself so that all that visual cortex is pretty much processing the good eyes, sensory input. When it's bilateral, then the whole thing is stalled, but it's stalled in a way that it's still recoverable so long as you fix both of them. So what's interesting too is that, the dogma that you have to fix a unilateral cataract by 4 to 6 weeks and a bilateral cataract by 6 to 8 weeks is being challenged by new data that shows that early cataract has a higher rate of glaucoma. And I'm now with Mimi and Leah and I are really kind of trying to push that number. We try to do the cataract surgery as late as possible because we have found that we are seeing the same thing in our own patients, that the glaucoma risk goes down, that there's something that happens with anterior segment development, that if you go too early, that surgical insult to the anterior segment's development into the angle puts them at a higher risk of glaucoma. Isn't that interesting? So bilateral cataracts, I'll try to wait the full 12 weeks, at least 10 weeks. But I'll wait often until about 10 weeks, sometimes 12 weeks to do surgery. You want to do it before they start getting nystagmus, because they will develop a sensory nystagmus if you wait too long. But I've even had kids who've come to me at 3 months of age with nystagmus, and we did the surgery and the nystagmus went away. So it's really interesting. We're in a period of time where this is being challenged just a little bit about how early you need to be. It's definitely not out of the gate you need to do surgery on these kids. Okay. This is another pretty tricky question. Secondary deviations are pretty tricksy. Okay, I'll keep going. Ooh, fantastic. Does anyone want to try explain this?
I can give it a shot because I got this wrong in clinic.
Thanks, Abigail.
So I think of it as, so basically when you are testing the eye that does not have Brown syndrome, you can get a much bigger deviation, which is the second deviation, and that's larger than the first. Because it's like a restrictive process. It can't move as much, and so
your audio just got a lot better. Whatever you just did, anyway. Keep going.
Okay, sorry. So it's a restrictive process because it's kind of the like the tendon sheath not being able to move correctly, and so to compensate, like the left eye, I think of it as kind of like a Herring's law thing of where it like works double time to compensate for the restrictiveness of the abnormal eye, and so the normal eye can give you a much higher reading or a much greater secondary deviation.
I love that. It is a great explanation. I totally think that's critical to invoke Herring's law here. So can I just offer one more kind of supportive explanation here too, is if this eye's down and it's a restrictive process that pulls it up, to get this eye to come up, this eye is gonna take a ton of work. I was gonna say it's gonna take, we'll just throw out like a unit of like, you know, joules of energy or something. It's gonna take like 100 joules of energy to get this eye just from here to here. But this eye, since there's no restriction, to get this eye to move up here, this one's gonna go flying up because your brain, because of Herring's law, is gonna send 100 joules to both superior recti to pull up and the inferior oblique, which is also pulling up. So this one's gonna way overshoot just to get this one up to here. Whereas if you put the prism over this side, so if you do a base up prism, so you leave this eye down and the prism straightens this eye out, then that's your primary deviation. But if you put the prism over this eye, meaning that you're gonna force this eye to be straight, this eye is gonna measure much higher. The normal eye, because to bring the restricted eye up to primary gaze is gonna be way more work, causing a huge amount of energy input or drive into the normal eye to just compensate due to Herring's law. That's I don't know if that's, I thought Abigail's explanation was great. Maybe I shouldn't even add anything. But do you have any other questions on that? Do you guys want me to explain that or talk about that, or any clarifying questions?
I just want to ask how often we actually measure a secondary and primary deviation, because it's really emphasized by BCSC, but I haven't really seen it in clinic.
So you do it in restrictive and paretic situations.
Gotcha.
So it's by virtue of those two not being as common, we just don't see it as much. But we definitely do see it. But on like a 3-month PEAS rotation, I just feel like you probably will only see it maybe a couple of times or a handful of times.
Gotcha.
And
So
with this,
go ahead.
The fourth nerve palsy still might be like a larger secondary deviation, but is it just bigger with restrictive processes versus paretic processes?
You know, that's such a great question, Cole. The reason that the fourth nerve palsy doesn't cause as much of a secondary deviation, it can. So the fourth nerve palsy is almost correct here, but because there's two muscles that depress the eye, you just don't get as big of secondary deviation.
Okay.
Would a sixth nerve palsy have a big secondary deviation? Potentially.
Yeah.
So if I had a left sixth nerve palsy, where do I want to put the prism in order to measure the primary deviation? Over the left eye or the right eye?
Over the left eye, right?
Yep. And if I force them to straighten out their left eye, which is a lot of work, and I want to measure the secondary deviation, I would put it over the right eye, but it's going to be a larger deviation because it's going to take so much work to get that left eye to midline that this eye, because of Herring's law, is going to get all this extra drive and is going to be more turned in. So hopefully these are great questions. Any more questions? Okay, we're going to start turning this into a little bit faster, rapid round. I'm sorry this is going. Well, I'm sorry, this has been really fun, but hopefully we're going to move a little more quickly. Okay, I'm going to keep going. Oh, I don't even need an explanation. Brilliant, because they're, what's the key factor here? The key measurement in their glasses that tells you to do bifocals and not surgery.
Ortho on the distance.
Yeah, and for those who don't know this, I probably should explain this. Apostrophe means the near measurement. No apostrophe means the distance measurement. And intermittent means, parentheses mean intermittent. Okay, we'll keep going. You guys
Yay!
nailed it. You nailed it. Okay, I think Marshall's gone, so we'll keep going.
Who is prisms for days?
Don't say anything, prison for days. Keep going. Okay. Sometimes it's, oh, nice. Yes, we already explained this. Does everybody understand that, right? So if they're straight and it's an intermittent deviation, the cover uncover test will show the other eye will have no refixation movement. But if there's a little deviation and you cover this eye, bam, you'll see that and you'll know that it's got, there's a small tropia there or a large tropia in some cases, but it's usually used for detecting a small tropia. I'm gonna keep going if that's okay. Okay, ending in 3 seconds. If you haven't done your answer, and stop. Fantastic, and I think we already covered this. So is it okay if I keep moving?
Yes.
Awesome. This is good.
This is such a classically Tyler situation.
Yeah, what the heck?
That's what happens when you grow up on a farm.
Okay, that's plenty of an explanation, I think. Ooh, okay. Oh, multiple answers. I don't think there's supposed to be multiple right answers on this one. Anyway, this is my first time creating a Kahoot. Thank you so much for your patience. I'm so sorry for the. If I selected multiple answers, so there could be multiple right answers. I think is what that's saying, but there really is only one true right answer. So, my bad. One more, and I'm gonna keep going. 3, 2, 1. What's the acronym? Or what's the mnemonic here? Do you guys remember? For remembering which one's AB duct and which vertical muscles AB duct versus AD duct?
I think of SINRAD, so superior is intort, recti AD duct.
Perfect. Thank you, Jennifer. And the secondary deviation is depression of the inferior oblique. Or excuse me, no, I'm wrong. Sorry, elevation. So it's the inferior oblique. Does it incyclotort or excyclotort? Inferior oblique here on a right eye goes like this.
Excyclotort.
Yeah, excyclotort, and because of the way it pulls, elevates and AB ducts. And I gave you correct for depression. That was a total. So whoever got depression, yeah, you're welcome. Because it's not the right answer, but we gave it to you. I gotta fix that. Nice. Okay, 3, 2. Nice. Great job. What's the main thing kind of missing in the newborn visual processing, like in the whole visual pathway? What's the main thing they're lacking right at birth that then forms over the first year?
They can't count fingers.
Yeah, it's correct. It's exactly what I was looking for. It's too good to change. So I'm gonna leave it at that.
Their foveal development.
Yeah, and it's the cones within the fovea especially too. So yeah. They have like this cone migration and then this kind of foveal depression that forms. So no way. I thought it was gonna trick somebody. That picture was supposed to show how nature adapts. You know, a tree was growing like over something. Well, somebody just give me a great explanation, short explanation, but a great explanation for this, because this was not obvious to me as a resident.
I don't know if this is perfectly right, but I think it's something to the effect of that your central vision is less accepting of small deviations and can't fuse that, whereas your peripheral vision is more able to sort of fuse two slightly disparate images, and so you suppress your central vision in one eye and have peripheral fusion.
Perfect. And to just add one more kind of opening line to that is monofixation syndrome is an adaptation to a microtropia. It's a small deviation. And another way I think about it, Sean, is on parts of your skin that have really highly densely sensory neurons, your 2-point discrimination is fantastic. So 2 points that are away from each other will feel distinctly different, and your maculas can't distinguish, can't fuse those together. But like your 2-point discrimination on your back, where things are more spread out, your sensory innervation is less dense. That 2-point discrimination is not so great. They can almost seem like it's just one. And I think of your peripheral retina as having like a poor 2-point or 2-point discrimination, meaning that they just can kind of fuse it together because it's close enough. So fantastic. It's pretty good. Okay. Oh, it's a drawing contest. It's a great one.
Dang it.
Lydia, do you feel, is Lydia still here? She's post-call. She's probably.
Yeah, I don't think so.
Okay, keep going. Ooh, this is really exciting. Okay. Okay, 3. Oh, nice. If I recall from last year's giant inflatable beach ball eyeball lecture, Sean Collin gave the most dramatic decreased saccadic velocity demonstration. So Sean, you probably should explain this.
I mean, how can I explain it with just words? The eye doesn't move as fast. It lags behind. It lags behind. So if you're testing saccades, it does this slow and dramatic swing across until it finally lands on its target. That's what it.
Yep.
The paretic eye, that is.
Fantastic. I realize I've been talking with my hands a whole bunch to explain things, but you guys probably don't even have the camera on, or do you guys have the speaker on? Whoever's talking.
We don't see your face. The game fills up the screen.
Okay. What?
I have a side-by-side view, so I see your face.
Gotcha. Well, it's probably I'm a hand talker, so forgive me. I've been doing all this hand talking. If you guys, and that probably wasn't helpful. Yeah, sixth nerve palsy is just you're exactly right. Weak lateral rectus means that it floats over rather than shooting over with the other eye. Perfect. Okay, I think there's some great kind of comebacks coming on here. Fantastic. I was hoping to fool more people with the calf eyes. But I think we all know that Abigail's about that. So Abigail, do you have any?
Life in Oklahoma.
I didn't mean to take a hit at Oklahoma. I was totally joking. Oklahoma's a great place. Yeah. Okay. Now. Amazing. Could somebody tell me a condition, maybe the most common condition that causes this?
So ROP.
Yes. Why?
Because they can have peripheral, just like retinal scarring, and then that can actually drag the fovea.
Which direction?
It will drag it temporally.
Yes. So if it drags it temporally, in order for the eye to align its visual axis, where will its anatomical axis point?
It'll point away
from the other eye, making it look exotropic, right? So I've got a question for you all. What would you do? And I have 2 patients like this. What would you do if you had a patient who looked ortho, but had an ET of 45 due to bilateral dragged maculas? So they actually have a huge ET and a huge positive angle kappa, but they cancel each other out in its appearance.
Don't touch them. What do you do about it? Leave them.
Do the surgery. I just wanted to be the opposite voice, but it seems like the ET could still cause an amblyopia.
So
maybe less likely.
Because isn't there foveas dragged?
Isn't there fovea what?
If their foveas are dragged, then by them being exo, then they wouldn't that align so you wouldn't correct them?
So to give you some more information, they are not fusing together. So they have to alternate fixation, and they don't look at you directly on. So when she looks at you with one eye, like if he looks at you with your left eye, both eyes turn to the left. So she's looking at you with the left eye because her visual axis is quite different from anatomical axis. So it's a really it's kind of a this kid will life will probably not be easy for them because they had such significant ROP. I mean, she's lucky to have, she has 20/40 vision, but hugely dragged and stretched out maculas. But she does have a true ET of 45. These eyes are not working together. To Sean's point, she alternates fixation. So she's not developed amblyopia. She has two eyes that both individually see well, but no binocularity. To give her binocularity and to correct her ET, I would do a big bilateral medial rectus recession, but her eyes would then appear 60 to like 70 prism diopters XT. So the answer that I've talked about with parents, I let them kind of choose, but they decided to just leave it. I agree with that because I think her binocular potential is poor anyway, just because of the RP and everything else. So she looks pretty darn good, and to help her visual eyes, to give her some chance to binocularly fuse, which wouldn't be great, and make her look terribly exotropic, we decided not to do. It's an interesting dilemma though. Oh, wow, amazing. Okay, it's just a fact, so let's keep going. Oof. Streak of 4 for ET Fun Home 2. Okay, I'll end it in 3, 2, 1. Okay, they're both correct. Why is blue also correct? What are you looking for?
Just any refractive component to their strabismus.
Yeah, if they've got some astigmatism and you correct it, what's that going to do to their control?
It'll improve their control because they'll be able to fuse clearer images easier.
Yeah, so if these numbers were 40 and 60, but it was still well controlled, would that change your management here?
No.
60 of at near.
40 at near and 60 in the distance.
Oh, okay. Not really.
If it's still well controlled, it's just to drive that point home. Control is what determines whether or not you do surgery. The magnitude determines what surgery you do or how much you move those muscles. Does that make sense to everybody? It's very easy to get those two mixed up. Okay. This is kind of a boardsy question or an OCAPS question. I have seen it clinically though. I have a patient who has both of these things. Okay, I'm going to skip it in 5, 4, 3, 2, 1. It's spina bifida. Cruzon syndrome. What is the motility issue in Cruzon syndrome? I'll give you a hint. Their orbits are both x-cyclotorted. Any guesses?
Isn't there a V pattern exo?
That's exactly right. Yeah. Because their whole, it's like their whole orbit is exocyclotorted. They have what's called pseudo inferior oblique overaction. Any guess, Sean, why it's pseudo?
Because it's not actually a result of the inferior oblique. It's a result of the whole muscle cone being. I don't know though.
That was like the perfect explanation. Well done. Okay. Okay. 3, 2, 1. Done.
What?
It's true.
Okay, hold on. This warrants sharing the screen here. Can you all see this video?
Yep.
This is my brother and his daughter, my niece, who is obsessed with Taco Bell. It's hard to hear, but she's chanting Taco Bell and she gets angry about it. Is that not the greatest video? I don't know why I think
That's
that.
amazing.
So just so you know, it's like we have people who are obsessed about it in our family, Allie, talk like even toddlers chanting it. I mean, we're really worried about you not having been there. So
You're missing out.
just kidding. It's okay. It was a great fun fact. I think these are really commonly asked questions on boards and OCAPs. The video here is to demonstrate that the obliques are working okay. Just get it? Oh, sorry. Couldn't resist. So we're waiting on 1 or 2 more. You guys are doing great.
This music is very tentative.
It's nerve-wracking, isn't it? Great way to make yourself anxious. Okay, we'll end in 3, 2, 1. Hey, fantastic. So who will just explain this again for us real quick?
This one. So like before, you shift the medials towards the apex, and it's an esotropia, so you want to do a recession, and then there's no oblique dysfunction. So no, and don't.
Perfect. Perfect. Thank you. Okay, there's still plenty of questions. There's 10 questions left to kind of catch up, so I'm going to try to go quickly. Are you guys doing okay? Is this getting too boring? Are you okay?
Over here, we're having the time of our life.
Yeah, this is great, Dr. Jardine.
You guys are nice. I know this is a long time to be doing this, but it's hopefully more fun than just being lectured.
Dr. Jardine, are you in your office right now?
I'm in Farmington.
I was gonna say come hang. We're in the library.
I would love to come hang. I've got clinic in Farmington, so I thought I'd do the drive before I started the lecture. Oh, I can skip it. Okay. You guys nailed it. Okay, we're gonna just keep going. What a crazy picture of an eyeball. I used the pictures that Kahoot offered, so some of them are a little weird. Thanks sorry for the oddity. To use these pictures, Catherine, I had to they wouldn't let me use the pictures they had, and they wouldn't let me invite more than 10 people without a subscription. So I'm on a trial period.
Okay, great.
If I don't cancel by Thursday, they'll charge me $120.
What?
But I'll cancel by Thursday. Don't worry.
Okay.
You guys got all right. So it's the spiral of Toulouse. It goes medial is how much? How many millimeters is the medial rectus on average posterior from the limbus?
5.5.
Inferior rectus,
6.5.
lateral rectus,
6.9.
6.9, almost 7, and then the superior rectus,
7.7.
So I've actually used this multiple times in scleral and open globes with a potential scleral perforation, where you're just trying to think, am I in front of the muscle as I'm trying to do this conch dissection and peritomy? And sometimes as you're even doing a peritomy where you're just trying to cut around the limbus, just take a quick measurement and think the medial's pretty darn close to the limbus, the closest of all of them. Let me just measure this so I know how much to spread my scissors out before I'm going to start dissecting over the muscle. And the biggest risk factor is not always that you'll actually cut the muscle, but rather you're going to just get into the anterior ciliary arteries that travel over the muscle and get into cause major bleeding and then lose your view. So you just want to avoid that insertion to avoid hitting those vessels and causing problems. I know this so well because I do so many retrobulbar blocks on my awake patients that I operate on. Oh, wait, I haven't operated on an awake patient in 6 years. I forgot what it's like to have to be, like ultra professional in the OR. That seems. Hail there 4. You got it. Just a great kind of a classic again, board's OCAPSy question. And I hope this is helpful to you guys in preparatory for OCAPS a little bit. So 2 birds with 1 stone with doing the lecture. Third chances has a streak of 9. It's amazing. Okay, ending in 3, 2, 1. Ooh. Okay, anyone want to take a gander at why that's correct? Think cranial nerve innervation.
So if like the innervation to the iris or the parasympathetic innervation to the iris constrictors, doesn't it travel along or with the inferior oblique muscle? So if you damage that, then it would be dilated.
Yeah, interestingly, it's not the muscle that's damaged. When you pull too aggressively on that muscle, you stretch the inferior division of cranial nerve 3, which innervates the inferior oblique and carries the parasympathetic fibers to the pupil. You got it. For those who haven't done the rotation, shooting your gloves into the garbage can at the end of the case is a really important part of the rotation. Yeah, everybody knows Mike well enough to know that he's the competitive soul who would submit that as his fun fact.
Or they would know that me, Marshall, and Ariana just kind of suck at it anyway. So
No. You guys made some great shots. Okay. You got it. You guys nailed it. I thought this would be more tricky because the 3-step test for a fourth nerve palsy is what? Who can walk me through that?
Can first identify the eye that's elevated, and then you do face turn and then head tilt. And if it marches out, so if it's a right hyper that's worse on left face turn and right head tilt, then it would be a right fourth nerve palsy.
Yeah,
And
that's all.
they'd adopt a contralateral head tilt because the eye will be X cyclotorted at baseline. And so if you towards the opposite direction, then it will mimic an intorsion of the involved eye.
That was so freaking amazing. I don't even have anything to add to it.
Can I ask a question about it?
Yeah.
So is it, I may have been thinking about this wrong. Is it a right hyper worse in left head turn or worse in left gaze?
Left gaze.
Okay. Just wanted to, yeah.
And then let me just use my hands again to explain this. So if I've got a right fourth nerve palsy, the superior oblique is a depressor in addition to an intorter. So the eye's going to be X cyclotorted and a little bit up. So let's say I've got a right hyper now, and then as I swing over to look to the left, it's going to shoot up even more because in adduction or adduction, we see that oblique muscles are doing most of the depression and elevation. So even though we talk about these muscles, primary and secondary deviation, I think that can get confusing because in adduction, the obliques muscles primary action almost becomes elevation and depression. So as the right eye is X cyclotorted and up, and you look to the left, it's going to really shoot up. And then when you go to the right, it's going to really pull up. So the two compensatory head positions they have is they'll go to the left, which will straighten their eyes out, or they'll turn their head to the left, both of which are contralateral to the pathology. I don't know if that's helpful, but it can be pretty confusing. Hey. Amazing. Okay, I'm going to just stipulate for 1 second while I answer this question.
Wait, crap. I think I got this one wrong.
Can't you change it?
No, once you click it, and also it's once you click it, it goes in, and then you also get more points the faster you answer.
Yeah. This is a tricky one. Okay. Well, you guys did a great job. This is a really tough one. It's almost just worth remembering. A right inferior oblique palsy, really tough to diagnose. They can look like a superior oblique palsy of the other eye, or they can throw you off. But the right inferior oblique, the inferior oblique's secondary action is what?
Elevation.
Elevation. So the right eye is down. So the abnormal eye is actually has a hypotropia. So there's a contralateral hypertropia, and then there's a contralateral. It's worse when the inferior oblique is in adduction. That makes it even more pronounced. So it's also worse in contralateral gaze, and then it's worse in contralateral head tilt because of its primary action being what?
Encyclotorsion.
So it's encyclotorsion.
Wait, is that right?
No, sorry. So the inferior oblique is
Excitation.
so when you turn your head away from the inferior oblique, your eyes want to turn back, and that's requiring that excyclotorsion. So so the other thing, so we always talk about the 3-step test being same, opposite, same for an superior oblique palsy. And an inferior oblique palsy, it's really easy. It's just opposite, opposite, opposite. So it's a left hypertropia and left gaze and left head tilt, where it's worse for a right inferior oblique palsy. I know this is probably painful for those who haven't done peds yet. So thanks for bearing through this. Holy cow. I thought my distractors were better. Yeah, cool. I'm wondering if this helps explain some of kind of your introverted calmness. It's just, this was such a traumatizing experience that you just maybe hold back a little bit. I'm just kidding. That was totally a joke. That was probably me.
For sure thought it was the vomiting one who was his neighbor. I feel like that's happened a couple
Sorry,
times this year.
I'm over here by Ariana and Marshall, so I don't know what's happening.
Okay, I'm gonna keep going. We got 2 left. It should be condition singular in this case. There's multiple ocular conditions, but
Was this book with the golden heart syndrome one of the images they created for you?
yes.
Wow.
Isn't that amazing?
The full version is worth it.
Okay. 3, 2, 1, and skip. It was so mean. Which ocular condition? Preauricular skin tag is not an ocular condition. That was just cruel. Cruel. I'm so sorry to have been so tricksy. Okay, last one for the win. Five, 4. Ooh. So, okay, let's talk about this. What do you think? What is the diagnosis?
Dacryocystitis.
So it looks, I actually would just call this an uninfected dacryocystocele. And it looks red, but there's not, it's hard to tell if it's infected just by looking at it. You just want to generally assess the kid's overall well-being, but this kid was happy, healthy, breathing fine, not fevering. How do I know it's not like an encephalocele?
It's inferior to the middle canthus, not superior.
Are you going? No, yep. Hold on 1 second. Will you give me a chicken, egg, and cheese biscuit? Yeah, just let me treat everybody.
No,
Yes,
stop it. No,
yes.
absolutely.
Yes,
not.
I would love that.
No.
Yep.
No.
Thank you. Thank you. I'll get breakfast, not lunch today. Deal? Deal. Okay, see ya. So sorry. So this is so sorry. So it's not infected, but it's hard to tell. And what do we worry about in kids under 3 months of age? With a true, if it was becoming infected and to turn into what Catherine said, a dacryocystitis, why is that so concerning?
Can cause breathing problems.
It definitely can cause breathing problems. Do you know why that is? These actually are bilobed. Go ahead. I heard the right term. Somebody's going to say it.
Are they obligate nose breathers, especially during beeping?
Yes. So these are often bilobed, and there's often a big cyst component in the nose, and they're obligate nasal breathers. And it can cause some problems. I could show you a pretty cool video actually that would be pretty interesting. But so you want to drain these pretty much ASAP, meaning like the next day or within a week. They don't often need antibiotics unless they get infected. But if they're infected, you've got to put them on IV antibiotics because a child's immune system in the first 3 months of life is not strong enough to fight this, and it's too close to the brain and other things. And you just want to just get this absolutely taken care of. So if it was infected, I would admit them for IV antibiotics and I would probe it the next day. Let me show you some videos, but we'll first finish this. Who was prison for days?
That's me.
Yay! Who's third chances?
That was me. That was the choke of the century.
Who's joyful dolphin? Is that Cole, right?
That's me. The dolphin. The dolphin.
You guys look so happy dancing on your podiums. I'm so happy for you. Okay. That was fantastic. Let me just do this real quick. So give me 2 seconds. Can I show you one really brief video of a dacryocystitis that is going to kind of blow your mind? Let me see this. I'm going to just see if this works. So here is a dacryocystitis that I think we tried to drain in clinic. See if I can't massage it down into the nose, but we'll see. So so this is how you massage it down. You kind of rotate it. You try to pop it both ways. She was so mad. So I massaged it in clinic. Isn't that so sad? Oh, it's so sad. She had a big old dacryocystitis. And you put a fair amount of pressure as you kind of press on it. Now that is a sad video, but that for that patient, it resolved the next day. The risk of that, which is maybe why it's not the best idea, is that you could pop it and then be sending some of that discharge and pus back down their airway. I actually don't do it a ton, but if parents are really adamant that they don't want to do, they don't want to go to surgery and they like almost refuse surgery, you can massage it pretty aggressively in a setting where you're going to watch them for a little while, make sure they don't have any sort of respiratory distress or other problem. And then let me see if I can find one other video that is just crazy. Am I still on screen share? So let me pull this up. Are you okay if I just share one more thing? Because these are kind of interesting, I think.
I guess there's.
Can you guys see this smaller video?
We can.
So this is a kiddo with a deck resistant seal before we probed it. Oh, no, excuse me. After we probed it, look at inflate and deflate every time she breathes. Do you see that DAC resistance seal inflating? So after we probed it, it was like inflating and deflating, and we had to we actually had her admitted in the hospital to just watch her for breathing purposes the rest of that weekend. So those are not easy, because what's frightening is that it can really obstruct their airway. Sometimes you do it in combination with ENT. I do these endoscopically, and I make sure to lance the cystic lobe inside the nasal passage. With a camera, I want to watch it. Anyway, okay, you guys, that was really fun. Can I get some feedback really quickly from you that I will fix? I'm so sorry about the answers that were wrong, or the one really important clarification is that on OCAPs, if they ask you, or boards, if they ask you about an ET that doesn't fully resolve on the first cycloplegic refraction, to redilate and recheck is probably very commonly going to be the right answer. I'm so sorry I didn't have that be an also right answer. That was my fault. Number two, was this an okay way to do it for future years? Is this, do you prefer, I didn't do any slides because I didn't want to get caught up doing too much teaching. I wanted to just be mostly fun cahootness. What feedback do you have on that? Any other feedback? You can either throw in the chat or email me.
No, this is great. I think because a lot of us probably watched your lecture on core, so it's a great time to just chat.
Okay, well, you did a great job. I could use this again in future years, but I'd love to get your opinions if there's anything you would do differently. And I welcome any feedback.
I think one thing you could
please.
do also, Dr. Jardine, one thing you could also do is, especially for those who haven't done peds, you could like pair up a junior and senior resident, and they could do it in teams, even in Zoom. They could just like call each other on mute or something. If you wanted to have like some of those more tricky ones be like longer times, but that's the only suggestion that I have, just because I think the junior residents do really well when, or even me who hasn't been on peds, it's like nice to discuss things with peers again.
It's a great idea. Great idea.
I missed the blow up eyeballs.
And what was that?
I missed the blow up eyeballs. I was hoping you were going to send me a set so I could model them myself in my living room.
I love the blow up eyeballs. They're all sitting in my office still in the corner. So we'll do that probably next year. Maybe I'll alternate or something. Okay. Thank you everybody for participating. Have a great rest of your day. Please feel free to, email me with any questions, and certainly check in with any, this is a rough time of year, just from short days and OCAPS prep and everything else. So hang in there. And I just really just love working with all of you. I think we've got the best residents in the country. Have a great day. Take care.
Thanks.